Good afternoon, everybody. Welcome to our event. Maybe also, if you like, you can sit a bit closer, but feel free as well at the same time. Good afternoon once again. My name is Fitsum Lako. I work with Waki Health as the African Union Liaison Manager. I'll be moderating this session. So our title for this event is titled Advancing IDA21 Country Priorities on UHC, Nutrition, and Jobs by Scaling Catalytic Financing. We're joined here by very able panelists. We have online Honorable Mokutu Makaleane, who is the chair of the NIAPACO. He's joining us virtually from Lesotho. We have also Rosemary Mburu, Executive Director of Waki Health, and we have also Waiswa Mkangwa, who is the Senior Technical Advisor at Management Sciences for Health. And finally, we have Cecilia Thomas, who's the Health Finance Lead at the Global Financing Facility. So welcome all. Maybe if you can confirm if Honorable Makana or Mokutu has joined. Has Honorable joined? Okay. So we hope Honorable will join. So today's session will be focusing on three main objectives. The first one will be to identify a practical pathway to accelerate progress towards the bank's UHC 2030 target. The second one will be to showcase scalable catalytic financing instruments, and that can also leverage on IDA and IBRD financing, such as the Global Financing Facility, debt swaps, loan buy-downs, and also blended co-financing with global health institutions. And third, to explore strategies to improve coordination and uptake of catalytic financing tools, such as through leadership by implementing country government donors, MDBs, and also global health initiative skills that work and overcome persistent implementation barriers. So, as you all know, within the current framing of global health, diminishing resources for health, and also the debt nature, which also bringing countries into financial hardship and challenges, illicit financial flows, which could have been also averted for economical gains at country level, especially for job creation and addressing structural economic issues, and also climate change, which is also, again, adversely impacting economies and taking also much competing resources to health. It is within this context that we're addressing this session. So shrinking ODA is another very pressing challenge that we're witnessing. Rising global crisis, and also we need to align financing for human capital outcomes. So I would like to, with this context, I would like to call on my able panelist. Kindly confirm if Honorable has joined. Honorable, can you hear us? No. Okay. So I would like to give each panelist few reflection points for their opening reflection. And I want you to focus on a broader spectrum and to reflect on persistent barriers and also greatest opportunities to accelerate progress towards the bank's UHC 2030 target and also the World Bank's job creation agenda through sustainable health and nutrition investments in line with country priorities. I would like to start by Rosemary Mburu. You have 5 minutes. Thank you.
Thank you so much. I hope it's clear. Yes. So it's an honor to be here to have this conversation, reflecting a lot around financing that helps the bank deliver on its commitments around nutrition, around even jobs, around universal health coverage, and broadly speaking, around human capital. So in terms of the persistent barriers, the first thing is to acknowledge and recognize that countries came out of a very difficult pandemic environment, and within that context, there was a lot in terms of services to populations, but also a fragmentation or weakening of the infrastructure, the health system, human resources for health, and many other health systems functions. And so coming out of that environment and coming out of that context, countries found themselves in an environment where their debt to GDP ratio was increasing, many countries being debt distressed, and many countries having to rebuild their health systems. So having that context in mind and thinking about the barriers, one is that we still have countries. I think many countries are still recovering, and countries didn't quite recover from COVID-19. If you look at some of the indicators, pre-COVID, there are countries that actually haven't been able to reset, to go back to the indicators, health outcomes they had before the pandemic. And that definitely puts a heavy toll and weight on health systems, on the economy, and any aspects. The other thing is to talk about, so you have that, and then you have many countries going through extreme climate. I'm from Kenya, and one of the things we saw last year is one of the biggest flooding experiences in Kenya. And what that meant is that you had health facilities that were flooded to the roof, so you lose data, you lose information, and rebuilding that takes quite a bit of time in terms of investment and takes away from services. So the climate crisis, if you look at it as an intersection between health and climate, also contributes to the challenges and the barriers, and many health systems are having to deal with that. And I'm saying that because when you think about making progress to universal health coverage, where everyone can access services wherever they are, when they need that without suffering financial risk, then you can see how recovering from the pandemic, then the intersection with climate continues to challenge that. In terms of debt situation, debt management becomes very challenging. I know recently we had a civil society meeting in Kenya, and we were looking at how the debt situation is limiting government's ability to invest in health or even in social sector, or even in human capital, whether it's education, whether it's health, nutrition, social protection. And one of the facts is that our debt repayment, the check we write for debt repayment is more than 50% of our revenue. And so you can imagine what that means in terms of the fiscal space and how much government has to actually then invest and scale up this initiative. So those are some of the challenges. And so even when countries access financing, when countries access, IDA countries, for example, even when they access, one of the things we need to continue to be better at is, and especially from the bank side, is to strengthen and improve the maneuverability of countries to actually invest in human capital, to actually invest in social services. That maneuver is not always there, and the balance between investing in infrastructure versus investing in women and girls or investing in human capital, there is always a skew towards investing in infrastructure. Infrastructure is good, and we need that. But I think when we talk about human capital development, even as something we need to create for more job creation or job growth, there is an intersection there. We really need to ensure that the environment, and we create an environment where countries can actually maneuver that ecosystem to actually be able to invest more in human capital and even in the social sector. So I'll offer those reflections for now. Thank you.
Thank you very much, Rosemary. Within the same line, I would also like to invite Cecilia Thomas to give your first reflection. Thank you.
Thanks very much. And can you hear me?
Yes.
Okay. Thanks very much. It's really a privilege to be part of this panel with you all and focusing on this important topic today. You know, as we at the GFF have reflected on some of these challenges, we're also seeing opportunities within them. So I don't want to, oops, sure. Countries are facing real challenges, and to echo Rosemary's points around the limitations in fiscal space, the debt crisis, these are real experiences that countries have currently. We also see development assistance for health going down. We see often the deprioritization of reproductive, maternal, child health services and sexual and reproductive health rights. With all of this in context, I do think there are some opportunities and sort of bright points coming out of that as well. The first I think that we're seeing currently is this movement towards greater health sovereignty, where countries, even though they are faced with these limited resources and the debt crisis, are really committing to domestic resources for health. And that leadership and that commitment is really a first step. And we saw this at UNGA, where several African leaders came together to commit to being less dependent on foreign aid. And that, alongside improving efficiency and attracting other investment, I think is an opportunity to move forward. We're also seeing that some of the system's inefficiencies and the fragmented financing are being addressed through work around strengthening public financial management, expenditure tracking for health, and really ensuring that resources are allocated and then spent to the most important needs of the country and to the most at-need populations. I also think that we should reflect on the important indicator and focus that the bank has put on achieving this 1.5 billion target. This is really a great opportunity for health and for maternal child health in particular, that it is a corporate commitment of the bank focusing on this going forward. And we do hope that that gives us a lot more leverage and breadth to ensure that we at the GFF are working to achieve these RMNCHAN goals. So I think this opportunity is really around placing governments at the center as we have, and empowering countries to lead and prioritize these most important needs. And so this shift towards greater country leadership and unlocking or finding efficiencies in financing is really going to lead us to sustainable progress. So we're also seeing a quite powerful movement around aligning partners to work better together. And I think we can see this with many of the efforts most recently, like the Lusaka agenda, so crowding in domestic and external resources in service of country priorities. And multi-stakeholder platforms that we're also seeing and supporting at the country level are really important for this as well. So with government stewardship and leadership, a multi-sectoral platform that includes donor partners, civil society, private sector, I really do think is an opportunity to strengthen and will benefit both the health system, but also job creation and broader human capital development. So a few of the sort of innovations or opportunities, I think, are aligning these investments with country strategies, catalyzing financing as a driver of change. So innovative financing mechanisms like the Global Financing Facility are helping countries unlock some of this financing, finding efficiencies, bringing donor funds on budget, strengthening partnerships as well. So this collaboration across donors, government, civil society is really an important element to this. And then finally, harnessing data and accountability. So I do think we're at a point where the AI and digitization landscape is going to be beneficial in terms of helping to track progress and learn quickly and adapt in many of these countries. And then, of course, last but not least, promoting equity and resilience. So focusing on inclusive investments, especially for women and children and adolescent and the populations that are most at need. So I do see this as a unique opportunity. Absolutely don't want to downplay the serious challenges that are also at play, but hopeful that we can make some progress. Thanks.
Thank you very much, Cecilia. Waiswa?
Thank you. So I will focus specifically on the UHC angle of this question, which is that in terms of barriers, every 2 years, the world, maybe get closer. So, okay, so every 2 years, the World Bank and WHO, they publish this report, the Global Monitoring Report on UHC, which tracks two indicators, service coverage and catastrophic health spending, out-of-pocket spending on health. And we're still waiting for the latest one later this year. But during the IDA21 replenishment, we actually realized during the campaign, we realized that the initiative, the 1.5 billion initiative, focused on expanding access and all other areas, but it didn't quite address or have a way to monitor financial protection from financial hardship as a result of having to pay out of your pocket to access care. And so we kept pushing them, like, what is this? There's no way to track this. There's no way to monitor this. Like, what are you? And they said, no, don't worry about it. We have it. It's a priority. We're going to focus on this. And so this, for us, remains a major barrier from where we sit in terms of UHC. It is nearly impossible to make the kind of progress toward UHC by simply providing services, making sure services are available, because there are lots of populations and communities that can't afford those services. In fact, that's really what UHC is about, leaving no one behind. And so if you don't address that cost element of it, you are not really doing enough. And so the bank has actually acknowledged that, and they say they will do something about it. But what we think is important is that they actually take, practical steps to make sure that people who either live in poverty or immigrants or others are not going to fall into poverty just to access the care that they need. But this is also a human capital issue, because if you're poor, we both know about poor people, you have very difficult choices to make when you're faced with a medical bill. You pull your kid out of school. That happened to me personally, which is how I actually ended up in this seat, was that my parents had to choose to get me out of school, or when I got sick, take me to the hospital to get the treatment I needed. And that changed my life trajectory until where I find myself today. And so those are the choices that you are making. Is most of the people will never get where I got. Their lives will end there. They will never get an education. And so there are serious consequences to not prioritizing this issue of out-of-pocket health spending. It is also, so it's education, it is housing, it is nutrition, people having to choose whether to feed their kids or to buy medicine. And nobody should really have to make that choice. And so one of the barriers that, we are paying attention to is exactly that. In terms of opportunities, I think that some have been mentioned here. The recent efforts around the Lusaka agenda, which Work Health and system we've been part of, the current discussions on the future, not future, but the global health architecture, I think that there are opportunities for us to look, with fresh eyes on how we can do things differently to accelerate progress on universal health coverage. I also say that we need data, and so we are really looking forward to the launch of the Global Monitoring Report in December at the UHC Forum in Japan. I think that will give us a sense of what kind of progress we are making on all these fronts, access, but also financial protection. And so that's really where we see the opportunities at the moment. Thank you.
Thank you very much, Waiswa. So I've been notified that Honorable Mokutu has joined us from Lesotho. So it's 10:35 in Lesotho, 10:35 p.m. Thank you very much, Honorable, for joining. If you are following the conversation, we're collecting some opening reflections, and we're discussing on the persistent barriers and also the greatest opportunities to accelerate progress towards the bank's UHC 2030 target, and also the World Bank's job creation agenda through sustainable health and nutrition investments in line with country priorities. So, Honorable, you have 5 minutes for your opening reflection.
Good evening.
Good evening, Honorable. We hear you very well.
Okay, I hope we can hear me well.
Yes, we do. Please proceed.
Oh, thank you so much. Maybe within the time that I have, I'll just go straight to the issues. And thank you for giving me the opportunity to participate even while this side. The issues that our countries are facing, so in particular, straight to the point, number one, we have got the persistent barriers to scaling up the catalytic health financing in Lesotho in particular. So, and one of those barriers is the fragmented health financing landscape. And two is the low domestic health investment. And three, the weak public financial management. And number four is the limited private sector engagement. And lastly is the lack of outcome-based financing models in terms of the barriers. So maybe on the fragmented health financing landscape, it's when we look at the funding stream for health and nutrition, there's the disjointment in that area, and then also a heavy reliance on external donors and limited integration of domestic and partner financing. I think that has been a huge hindrance to really making sure that we overcome this part. And on number two, on the low domestic health investment, we still, this year, our budget falls at 13% of the national budget, which is 2% below, and we hope this coming year we may overcome that in order to meet the Abuja targets. The weak public financial management also is caused by the delays in budget execution because of low absorptive capacity and poor alignment between planning and funding, which reduces the effectiveness of health resources use. The issue of capacity in terms of the governance, you see it from the facilities, health facilities. Lesotho is one of the countries with the high access to health and the facilities throughout the country, but we still have a high mortality rate in terms of infant mortality, and so we look at that from the capacity and the skills challenges. And also the private sector, there's a minimal leveraging of private and investment in public health and nutrition interventions. So that we still try to engage and mobilize the private sector to come to party more effectively. most currently financing is input-based, but it's not performance-driven. And then there's a limited innovation and accountability for results. So how the IDA21 innovative financing can unlock progress, we are looking at the flexible country-driven support, the Human Capital and Climate Resilience aligns well with Lesotho NSDP2 extended, which it provides an avenue for multi-sectoral investment in nutrition and then smart health systems. So we also looking at the result-based financing and then blended finance guarantees and the support to strengthen PFMA systems. So over the years also, there's been a lack of really putting nutrition as a cross-sector entry point. So that have limited some of the benefits that we could have gotten if we had a support of the integrated health and agriculture and then education interventions, which would deliver both nutrition outcomes and job creation, especially for women and the youth. So I think on this, looking at the universal health coverage, we think we still have some leverage to maybe draw from the innovations. The king in the country is he is one of the champion of nutrition, as you know, with the which was done by FAO. But also we wish to make sure that we can reduce the issue of standing using some of the support from the donors. We have had at the bank's support for years. But maybe looking at what as the countries we must do, maybe to change this picture that I painted when I started. We're looking at the country strengthening the policy coherence between the Ministries of Finance, Health and Planning. And we are looking at integrating and universal health coverage and nutrition into national budget priorities, and then not rely solely on donors. That's why this year we have already started discussing the issue of the budget cycle and looking at the domestic funding. So one of the things that we have planned to do is to start with this year, making sure that we have more domestic funding that is a bit comprehensive around critical issues. And then one of those is that on HIV/AIDS treatment, we are covering 83%. And then on TB, we have covered all the other TB treatment except for the second line. So we are trying to make sure that we can increase the coverage on those key elements and then the critical points or essential medicines on that. We also use the parliamentary oversight to track health financing flows, which maybe previously we are not looking at it closely. This week we had NCDI's a huge meeting of multi-sectoral coordination, which as a parliament, we were looking at that, using that leverage of a multi-sectoral approach as a way to make sure that everybody is involved, but everybody takes part. And we believe that Lesotho, since it's a very cold country, we don't have many other diseases, but we have failed to manage some of those. But we also have a very good examples in terms of how we managed a lot on HIV/AIDS, to the extent where we have reached 90, and 95, all those targets that we were supposed to reach. So we wanted to use that. So how we're doing that, we're looking at our priorities focused on primary healthcare and then integration of services. So because that helps that one person cannot be coming to the health center 3 times a quarter, but because there's something that we did not do or did not check or did not test. So we are already piloting that a lot, that the integration of services takes place. Well, but we also look at the strategies. Right now we are doing the assessment of all the health legislations. The health policies are being reviewed, like the public health. We are reviewing that, plus the NCD's strategic plan coming up. But we are also doing the restructuring of the health sector. So we believe those will help us eventually. So we are also looking at building the data systems. It's true that previously we were online with the health systems strengthening. It was through the project of the MCA, which has since been stopped. But we are trying to adjust to make sure that we can still continue with our e-health systems that we wanted to build. So I think with that, some of those ideas that we are trying to put with the partners may give us some fruit. So we are testing that. In few weeks, we'll be in the fields in the 4 districts, high disease burden districts, especially with TB and then other diseases, that we are focusing on those, the campaigns, huge campaigns around those areas to see how far we can go. And then see how we sustain that over the period of time.
Thank you very much, Honorable. Actually, you have really set us for the next moderated session. And we also would like to hear more, especially on the country experience and priorities as well. I would like now to focus on how we can, or how scalable catalytic financing for human capital can even foster job creation, address UHC, nutrition, and other areas that the bank is heavily involved at country level. I would like to take this question to Cecilia. In what ways can the GFF leverage catalytic financing, also aligning funding and mobilizing domestic resources to accelerate progress towards UHC and also World Bank's job creation agenda? You have 5 minutes.
Thank you. So the Global Financing Facility for Women, Children, and Adolescents is one of the key partners in realizing helping countries translate the IDA21 priorities into results. We work the GFF supports 36 countries. We work together with these countries to support development of investment cases focused on UHC, nutrition, and RMN, CHA, and services. And these investment cases are co-financed by IDA IBRD with GFF with GFF grant financing. So what is catalytic about this financing? This financing really aims to crowd in both domestic and external resources by aligning partners around a single investment case or country strategy that leverages the IDA financing and adds to that grant financing that ensures that resources are allocated to spend on countries' most pressing maternal, child, and adolescent health problems. And this includes work as well to support improving how resources are spent. So supporting public financial management and expenditure tracking, as well as alignment of partners at the country level. And that really drives reforms in service delivery and governance and accountability. So some of the work as well that the GFF supports around domestic resource mobilization and use, so actual spending of resources, includes things like improving tracking of resources across the system for health, mainstreaming performance-based financing in government systems, supporting benefit package revisions and aligning payment methods to those to support greater outcomes for the money. So, for example, recently Nigeria's resource mapping supported in Nigeria by the GFF was used last year by the Honorable Minister of Health to help align the donors around Nigeria's top priorities. And I'm sure you've heard this many times already, but that top priority is really around crashing maternal mortality. And so using these data on not only government financing, but also donors and the fragmented financing that Honorable was just talking about, to be able to align and say, these are the priorities that this country has, how do we best resource these and make sure that we're complementing and not duplicating efforts. The GFF has also supported nutrition responsive budgeting, and in Rwanda has done this work which really helps to mobilize and track the effectiveness of nutrition spending. So again, speaking, Honorable was speaking about some of this integration of nutrition across the system. It can be very difficult as well to be able to track and mobilize and then see the spending coming to results for nutrition. And some of this nutrition sensitive budgeting work is very helpful in that vein, and the GFF is working to scale that up in several countries. The GFF has also implemented country presence, kind of brought that to building that capacity in terms of the country coordinators that we support governments with. So these coordinators are embedded within the World Bank and the Ministry of Health. They work alongside government to help translate those priorities and do a lot of this alignment work that we're all talking about. We've also supported strengthening some of the country platforms and policy dialogues, so thinking about these multi-sectoral platforms that involve government as the lead, but with development partners and civil society, private sector, playing their parts as well. So, for example, the GFF supports the JCF, forgetting the what that stands for in Ethiopia, that brings together these partners, and actually has also developed essentially the swap mechanism that is part of that platform. The GFF investment cases are actually increasingly integrating nutrition and human capital priorities and supporting these multi-sectoral plans and job creation through investment in the health workforce. And in Bangladesh, GFF and IDA funds recently supported this multi-sectoral nutrition plan and created jobs for frontline workers, linking health and nutrition and economic resilience. So thinking ahead and looking ahead under the IDA21, the GFF is really focused on scaling up this catalytic financing, and some of the examples that I mentioned to you. We're working on strengthening country systems, on driving results and better data use. And one example I can give is helping countries respond to these real-time shocks or real-time challenges that we're facing. So whether that be COVID or the debt crisis, or more recently retraction and in development assistance for health, helping countries understand what money was there, what has been lost, and what was that money being spent on. And now knowing what those gaps might be, and knowing what the service delivery priorities are and the status of service delivery, how can we rapidly reprioritize and adapt to that context? So that's just a kind of example of some of the work that we're currently supporting. So I guess in summary, we're really working to within our new strategy, which starts at the beginning of next year, to have governments at the center of this health financing reform, and mobilizing more and smarter health financing for country-led RMNCHAN, accelerating the progress on these indicators by targeting populations that are most at need, and also focusing on commodities and innovations, and strengthening country leadership and capacity to sustain health and nutrition gains and bolster resilience.
Thank you very much, Cecilia. I would like to come to Waiswa. So Waiswa, at regional level, how can African institutions like the African Union and also the Lusaka Agenda help to coordinate financing align donors, GHIs, and also countries to strengthen UHC implementation for nutrition and health. 5 minutes.
So, I mean, regional institutions and the Lusaka agenda are related, but yeah, let me explain a little bit of that. But so, you know, for the last few years, we've been involved along with Work Health in the push to make the Lusaka agenda a reality. The Lusaka agenda, I don't know if people are familiar with this, but this is an initiative that came out of the Future of Global Health initiative that was launched a couple years ago by the Wellcome Trust to try to look at and assess some of the gaps in global health financing from a global health institutions standpoint. And so they looked at, you know, GFF, they looked at the Gavi, the Global Fund, and others, and they identified some of the areas and barriers that needed to be addressed. And then after they did that, they sort of handed it over to others to take it forward. And so the Lusaka agenda was born in Zambia, which is why it's called the Lusaka agenda, because it was endorsed in Zambia or launched in Zambia in 2023. And you know, the idea was that they put together a set of recommendations or shifts that need to happen in order for GHIs to be effective, working alongside governments to deliver care to people who need it the most. And so since then, you know, the question was, this was a global agenda, but, you know, you can write a document and put it out there, but actualizing it is another thing. And so the question was, how does it move forward? And so the African Union really stepped forward with the Africa CDC and also the WHO Afro our office to push this forward in Africa, basically. But again, it's not an African agenda only, it's a global agenda that Africa decided, or the AU decided to really champion. And so, you know, there have been a lot of conversations, meetings about how would this look like. The very beginning was to decide on a set of countries that are going to try this out. And the idea is that the GHIs try as much as possible to align their work plans, their budgets, their monitoring and evaluation frameworks with the government, so that, you know, they're working together as one. So it's one report, one budget, one work plan. And so the GHIs actually were on board, and they agreed with that. And member states also joined, including donor member states. US, Canada, and many others were supportive, the EU, France. And they started on the road to actualize this with champion countries in Africa. But then, obviously, we had what happened in January, and so now we are back to the drawing board to figure out, is, you know, the Lusaka agenda sufficient to address what needs to be addressed now in terms of financing. And to that end, lots and lots of consultations are going on right now. Dialogues are happening at different levels, regional levels, and also at the global level. We are part of those initiatives where Work Health and as the civil society engagement mechanism for UHC 2030, we recently launched a project that is mobilizing civil society to prepare them to feed into these discussions at the regional level, at the country level, also at global level, as best we can. And we are hoping that at the end of all of this, that we'll have a better, at least, understanding of what we need to do with the resources we have, which are much lower than what we had a year ago, to help countries, you know, take on, you know, the challenges they're facing. But the Lusaka agenda still remains relevant because it was built around country leadership. And so it's still playing a role in these conversations, and we hope that we continue to build on it. and build it out to our this new whatever ideas will come out of the consultations that we are seeing on the future of the Global Health Initiative. So yes, in terms of regional institutions, they are doing, at least the AU is playing its part. One would say that the EU played a part in terms of supporting as well the Lusaka agenda. We've heard from member states still supportive. For example, Japan and others have kept reiterating this at the General Assembly, last UN General Assembly. This was still in people's minds as the way to go, the Lusaka agenda, and also the reimagining or the reforming of the global health architecture. Yeah, and I know, Rosemary, you've been very close to this, so maybe if you have anything you'd like to add to that.
Yeah, thank you. So, Rosemary, also you can reflect on that. Also, I want you, Rosemary, to focus especially on what kind of catalytic financing is needed to advance UHC policies, and also how is the bank financing and also the UHC target helping scale financing and progress on this issue.
Thank you so much, Waiswa. You are spot on in terms of the Lusaka agenda and the work we've done together on that. And now we see that, like Cecily mentioned, the Accra Summit on sovereignty has also come up and very much aligned with the same principles that Lusaka agenda brought forward, especially emphasizing country ownership, country leadership, domestic investments, and so on. So that's an area that is growing quite a bit in terms of, especially in Africa, just looking at, the evolving global health architecture, how financing decisions are made, who makes those decisions, and what issues get prioritized. Moving to the question, what kind of catalytic financing is needed to advance UHC policies, and how are bank financing and the UHC target helping scale financing and progress? I see there are two questions in that. One is, what kind of catalytic financing is needed to advance UHC policies? And I would say that, different countries experimenting or trying out different catalytic financing models or innovative financing models. I know we've already heard about the GFF, and that's great. As a global health financing institution, and the domestic component and the core financing, we also have other global health institutions, like the Global Fund, like Gavi. So broadly speaking, there is an opportunity there with global health institutions, core financing, and how that can help contribute to UHC in terms of investing in equitable access to health services. And there are countries that are trying other models like debt swaps. There are countries trying loan, buy down, social impact bonds, and so on and so forth. I think for me, in order to advance UHC, whatever model or mechanism a country chooses, whichever direction they choose to go, I think there are certain principles that we want to see this catalytic financing meeting. And within the Africa region, they are very much articulated through the Africa Leadership Meeting on Investing in Health, that is the ALM. So the ALM is a regional framework. You could call it the health financing blueprint for the region. And African Union member states have, endorsed that and are working on that at country level. But what is exciting is that within this framework, it offers a number of tools that countries are following. And I think that catalytic financing should also align to those principles. For example, when we look at health financing and how we track and we measure that, a lot of the times is against the targets. Is it meeting the 15% Abuja, $86 per capita as WHO recommendation, 5% of GDP, and so on and so forth. But within this framework, you also find a tracker that tracks not the quantitative absolute number, but it tracks the health financing environment to see, is a country making progress towards financing that can be impactful. And there are 4 things which I think this is the kind of catalytic financing that is needed. Catalytic financing that is additional, like brings additional money to the table. We also like to call it more money for human capital, whether it's nutrition, health, social protection. So more money, we want to see additional resources. But also we want to see better outcomes. That's the other principle. And I think that's the kind of catalytic financing we need. Whatever model we choose, it should contribute to better outcomes, for women and girls, for nutrition, for health, for immunization, and so on and so forth. The other thing is governance. How the resources that are governed at country level is very important. And we are seeing this governance of financing emerge more and more as we talk about reimagining the global health architecture. How that money is governed is very important. What is the policy environment, the health financing policies at the country level? And is the catalytic financing, whether from global health institutions or the other innovations, actually governed by the same policies? And this is what we are talking about, country leadership as well, to ensure that as when catalytic funding comes from external sources, it really needs to align to a country's governance structures and policies. And that's where there are gaps right now. And the 4th one is equity. We want to see catalytic financing that contributes towards equity, meaning that we need to identify in every country, which populations are being missed by health systems, or which populations are less likely to be reached by services. When we talk about the last mile, when we talk about 4.5 billion people around the world not accessing essential health, who are those people? And how can we ensure that this catalytic financing is prioritizing those pockets and those gaps? And the last thing is to say that the kind of catalytic financing we want is the one that helps to unlock local resources and also promote country leadership. And country leadership, we are not talking about government. We are talking about whole of society, government, civil society, parliamentarians, private sector, everybody, whole of society. Very quickly, just to reflect on the second part in terms of like how bank financing and the UHC target helping to scale finance. The only thing I can say about this is that I might not know yet, but I think one way to go about this to ensure that the bank financing and the UHC target helps to scale financing is to make sure that the investments are using primary healthcare as the entry point. So that's my reflections on that.
Thank you very much, Rosemary. I know we're pressed for time, but I believe we'll have more time to discuss even on some hanging topics that come from this first session. I would like us now to discuss more on partnerships, especially in shaping financial solutions. So what collaborations that we need, especially what collective approaches can we have in our respective influences and constituencies, and what are enabling conditions for success are there from communities, civil societies, GHIs, and also other stakeholders. Honorable Mokutsu, I would like to start with you, especially in giving us some country perspective, and also to start with how members of parliament can ground especially discussions in advocacy, political will, and local accountability to further also have more influence in these decisions on nutrition, health, and also broader health issues at country level. Honorable? And if you can also put your video on, we would really like to see you. Thank you. Honorable, are you with us? If you're speaking, maybe you might be muted.
Hello, I hope you can hear me.
Okay, we can hear you. Can we see you? Is that possible?
I am trying that, but I don't
Okay.
know why.
Okay,
I
please
cannot.
proceed.
I don't.
Okay, please proceed.
Yes.
You have 5 minutes.
I'm-
Oh, great, great. We see you now. We see you, but if network is a challenge, feel free to go off video.
Okay.
Okay, please proceed, Honorable. Honorable, can you hear us now? Okay, I think Honorable has some connection issues. Rosemary, let me come back to you. So, at regional level, and also as Wacky Health being a regional civil society, how can we emphasize, especially structured engagements for advocacy strategy, and also bridging the gap between global institutions and communities? Thank you. 5 minutes.
Yeah, very, very quick. I'm conscious we are running out of time. But I would say that civil society has a very critical role to play in these partnerships, and accountability and advocacy is one of them. Accountability, really meaning that these investments, like if you are talking about IDA investments, for us to ensure that IDA is equitable, more IDA countries are accessing this financing, even given like the debt distress many countries are in. So in terms of access, in terms of accountability for results and for the financing, civil society is very important. And so I would emphasize structured engagement in the sense that right now, with many global health institutions, including multilateral development banks, the engagement with civil society can improve. That's an area where we can definitely see improvement, and we continue to engage these institutions. When we talk about, for example, the UHC initiative, we know that civil society has been involved here and there, in the launch, at the launch, and so on, some webinars. But it would really be useful if the partnership with civil society, even for this UHC initiative, to be more structured, so that when we talk about expanding services, when we talk about reaching the last mile, when we talk about reaching communities who are most likely to be missed by health systems, a structured civil society engagement with that and many other initiatives really helps. The other thing is, as we focus on partnerships, as we focus on the UHC initiative, even as we focus on IDA, it's very important to then think about how can we promote a relationship with civil society by ensuring that there is more transparency that really then also helps accountability. Because if these investments are going to be equitable, then we will need real data, for example, community-led data. We will need real-time information. Where are services reaching? Where are services not reaching? But also in decision-making, one of the challenges we have is that as communities and civil society, even as we talk about social participation, we rarely get to see the financing frameworks that our countries have with the World Bank, for example. Those financing frameworks are not documents that civil society in our accountability work and efforts have access to. And so it limits the ability for us to actually engage in effective accountability. So when we think about partnerships in shaping financing solutions, I think it's really important there is transparency, there is accountability, there is meaningful engagement, and the gap between the institutions, whether it's the global health institutions or the multilateral development banks, that we close that gap between those institutions and communities and civil society by figuring out how to strengthen that engagement in a structured way. Thank you.
Thank you very much, Rosemary. Honorable, are you back with us? Honorable Makutu, are you back with us? Okay, so I'll proceed. Waiswa, so within the spirit of partnerships, also and as a critical stakeholder, what can you play in supporting scaling of financing, implementation, coordination, and also accountability for scaling health and nutrition financing? 5 minutes.
Yeah, we're civil society. We are going to always continue to play the role that we play, which is push governments as much as we can, hold them accountable. But I want to speak to the piece around the enabling conditions. So we can't push everything or anything in the vacuum. There has to be a place where you can engage meaningfully. There has to be a willingness on the other side to engage civil society, to engage other stakeholders meaningfully. And this is the challenge we always run into. We do have tools now that we didn't have a year ago or a few years ago. We have the World Health Assembly Resolution on Social Participation that was passed in 2023 in Geneva, and it gives us a platform to demand governments to create those spaces and to institutionalize participation of communities, of civil society in decision-making processes, in how they design programs, in how they implement those programs, and also how they evaluate it. It's not enough to ask for money. There has to be some level of accountability. There has to be some level of not just accountability toward the government, also civil society, where we don't do our part. And so the enabling environment is, at the moment that we are pushing at UHC 2030, is for member states to implement the resolution and the commitments that they made 2 years ago, so that then we can begin to hold them accountable. And we do know that when you do that, when you create or institutionalize social participation, meaningful social participation, that there are positive things that can happen. We've seen that with all the challenges with JHIs, but you can see that they have sustained the engagement of stakeholders, whether it's the Global Fund or Gavi, and has made a big difference. And when you talk to civil society, they feel like this is also their own work, and they're contributing to the impact that these platforms are having. And so I think that that's what we need, is creating the enabling more of that by implementing the resolutions of participation.
Thank you very much, Waiswa. Honorable, are you back with us?
Yes.
Thank you very much. So we're discussing about partnerships, and also wanted to get your perspective, especially on how partnerships can further scale up investments on UHC and also scale financing for health and nutrition. You have 5 minutes.
Okay, thank you so much. I'm looking at the continent of Africa also, not just the country level. There are a couple of things that I think if we were to really capitalize on, for instance, like pool procurement. I know in the SADC region, we're looking at the SADC pool procurement services. I think that's one of the elements that could help in terms of domestic funding, so that when we are asking also for additional funding, it should be on the critical programs that enhances what we are already doing. So, and on that, we're looking at also the issue of EXA in our area in terms of Eastern and Central Africa. We are looking at that collaboration. If we can build a partnership in terms of the skills between ourselves, and even if it's through the camping and assisting other countries with those capacities within our regions, both SADC, East Africa, West Africa, and then all that. And it could reduce a lot of dependency on the actual liquid funding to the certain extent, so that the critical elements that we need to fight and be assisted, like building the sustainable systems in terms of our financing mechanisms within the countries and then across the regions, that's where the banks can come in and the donors can come in that particular fashion. So I was thinking that in terms of the continent of Africa, also building the system of oversight instead in terms of the parliament, the sustainable systems that looks and continues to scrutinize how these resources are being used.
Honorable? Honorable, you're with us? Unfortunately, Honorable, we've lost Honorable. Cecily, let me come back to you. I know I've been calling you Cecilia all this time. Forgive me. So what is GFF's perspective, especially on partnerships to achieve this critical topic, especially on achieving or scaling health and nutrition financing? Thank you.
Thanks very much. I think you had it right the first time. It just became an evolution of a name. The GFF is a partnership that brings together government leadership, the World Bank, other donor partners, civil society, private sector, and we really see partnerships as the way forward in terms of achieving universal health coverage for countries and scaling up health and nutrition financing, with each of these players playing their part. And I think just to echo some of the comments that have already been made by other speakers, and Rosemary mentioned the whole of society approach. We really see that as the way forward, and particularly with that government stewardship and leadership function of bringing donor partners to align with their priorities, and ensuring that they continue to do so. So there's really a function of government to play that stewardship and that leadership role, but also others, like civil society organizations, as has been noted, to play that accountability and that advocacy role. So building capacity of local CSOs to play that role is really important. It's also very important for the donor partners to, as have been described here, align to not only the country plans, but to these initiatives that are working to improve coordination amongst the global health initiatives at the country level. And then finally, I think there is a role for private sector to play in some of the innovations that they bring to bear. One example that the GFF has supported is in Tanzania with the Safer Births Bundle of Care, which is a partnership with the Tanzanian government, the GFF World Bank leveraging IDA funding, and UNICEF, UNFPA, Canada, Ireland, and probably someone else that I'm forgetting at this moment in time. And it's using an innovation that was developed through Lærdal Global Health Initiative, which is a Norwegian nonprofit, which really developed and supplied the clinical tools and simulation-based materials. And so this is an example of a partnership where each player is playing their part, both bringing the technical expertise and the financial resources to bear. And this innovation and partnership has really moved rapidly from pilot stage to implementing in 75 facilities in Tanzania, and there's been a significant reduction in neonatal mortality and strengthening of emergency obstetric and newborn care. So I think we really need to lean in to these partnerships and be clear about the role that each of us plays in this ecosystem, which I think is coming across in a lot of what the speakers are saying here. Thank you.
Thank you very much, Cecily. Honorable, if you have joined us, I'll give you more time during the Q&A session. Now I would like to open the floor for question reflections. But before that, I would like you to give a round of applause for our able panelists here and for yourselves as well. So I would like to open the floor for questions. I think given the time, we can take 3 questions from each row. The gentleman here.
My name is James Mwangi. Oh, all right. My name is James.
And also to whom you're directing the question.
No problem.
Thank you.
My name is James Mwangi. I'm a founder for Hope Child International. It's registered in Texas and working in Africa. Now, I think I'll ask 3 questions to Cecily. The first question would be, how does GFF tailor its support and investment priorities across countries with different contexts like DRC and South Sudan? The second question would be, how does GFF envision the role of local organizations in improving maternal, child, and adolescent health outcomes in diverse settings, urban Kenya, post-conflict South Sudan, and rural DRC? The third question would be, what innovative financing models has GFF used in Kenya or DRC that could be replicated in South Sudan? And the final question would be, does GFF provide technical assistance or capacity support to strengthen local NGOs' participation in health sector planning and monitoring?
Thank you very much. From this row. Okay.
Oh, sorry.
Your name and to whom you are directing the question.
Okay, hi, I'm Shan, and I would love to have my question for Rosemary. I guess my questions are really kind of like straightforward. It just we are really intrigued by. So I am working on global health financing projects, specifically focusing on sub-Saharan Africa at the moment. And I guess a lot of things you just like mentioned about really set a stage about what we are actually tackling. It's not just like competing priority for the global health per se, it's also like a kind of a shrinking physical space now at the moment for the government. But while we are also thinking about really having the sustainability for the delivering care, it's really kind of a mainstreaming to the public facility, to the government to really take on the responsibility. So I guess with those, our thesis really drew down to really the depth swap idea, thinking about really free up more the physical space for the government so that they are also kind of more comfortably about taking on the response. But I was like, would be great to have your, just like giving you mention about that. So I would love to have your view about how we can really materialize that and really making that a replicable model across the continent or maybe for more LMICs. Thank you.
Thank you very much. Please.
Thank you very much. This is Luisa Martinez-Richterova from Development Finance International, based in Washington, D.C. Question would be for Cecily, please. If you could give an example on some of successful private partnerships you have had through the GFF in Ethiopia, for example, or also Nigeria, and particularly in the topic of diagnostics, if that is the field you also support, and also MMS, particularly as part of maternal and child health. Thank you.
Thank you very much. Any last question? Any burning question? Sochio?
Hi, thanks everyone. Sochi from Action. A few of us, I know in the room, but we were just at the IDA forum, and one of the gentlemen talked about how, after looking at kind of, from the economic perspective, the biggest issue with the jobs, agenda that we're all trying to achieve is human capital, right? He said that very, very clearly. And so I think in terms of just, the conversation right now and how we can support countries in helping drive that jobs agenda, is there, and this is, I think, to all the panelists, like, what in particular in human capital do we need to drive down more at the country level? And I think just from your perspective, what can the bank be doing to help support countries in driving this, right? I think we see that there's an eagerness, especially in the African continent, for greater leadership and in driving this. And so I'm just curious to kind of hear from each of your perspectives what is needed. Thanks.
Thank you. So this is a general question? Okay, thank you. Cecilia, I know you have a chunk on your table. We can start with you.
I'll start, and I'm sure the other panelists have additions that they could make as well and reflections on GFF. So the GFF does work in 36 countries, and you'll have to tell me if I'm answering all of these, addressing all of the questions that you raised, including the DRC and Kenya, not South Sudan currently. In terms of these very different contexts, that is certainly the case. Little under half of the GFF countries are fragile and conflict-affected regions. We have a real broad variety of what that includes, whether it's conflict zone versus no interaction with government. It really varies, and we do take this similar approach in all of the countries in terms of the partnership approach, in terms of supporting government, in terms of aligning with the country's priorities and investment cases. So in the DRC, we have worked to align an investment of, I believe, 200 million IDA to really focus on priorities addressed in that investment case. And I can share the sort of access to these investment cases as well. In Kenya, we have invested in an IDA project that has just been completed that worked in many different counties, working to mobilize additional domestic resources for women, children, and adolescents. We are now moving forward with an investment in the new IDA operation in Kenya. In terms of the role of local organizations, and I assume you mean some of the CSOs, et cetera, the way that we engage as GFF is to support the country in these multidisciplinary and multi-sector platforms, first of all. So to ensure that there is representation from civil society, that there is representation from the private sector. Rosemary was mentioning some of the needing more transparency on the World Bank operations that are ongoing and what financing is going towards. So this is some of the work that we do to ensure that CSOs have access to that information, to support and encourage feedback on these operations in terms of increasing budget for RM and CHAN for women, children, and adolescents, and ensuring that the money is actually spent on those services and that there are demonstrable outcomes from that. What are we doing to help local NGOs? So that's one part of it. There is an element that the GFF works with the World Bank more recently through the civic engagement, where the GFF is supporting local CSOs across the GFF countries to build their capacity in doing exactly as I just mentioned. So in this budget advocacy, in accountability, but also in organizing and in maintaining platforms themselves. So there is an element of the GFF support that had been doing some of that and engaging in the African Leadership for Investing in Health initiative that Rosemary mentioned. And going forward, there is some new funding that will be put towards that, probably to be announced soon. Hopefully that covered several of your questions, and happy to follow up more. Someone had questions around the private partnerships, specifically some of the work on diagnostics. So there have been several bits of work that we've done related to private sector. Some of this relates to engaging local private sector providers of services and products. So that's thinking about how can we use government financing to bring in and ensure the quality of private facilities providing care to the population for ARM and CHAN care. And that's really more about connecting and purchasing those services from the private sector. We've also, as I mentioned, engaged in some of these partnerships around specific innovations. So the SBBC model, and scaling that up with partnership from organizations like Laerdal. We also support a partnership, an investment in Cote d'Ivoire, for example, that is a hybrid public-private partnership model with the IFC that is specifically focused on bringing diagnostics to the populations that we're most focused on in terms of women, children, and adolescents. So several that I can think of. Nothing comes to mind in terms of Ethiopia at the moment. There has been some work in Nigeria before that I'm happy to point out to you. Shall I stop there?
Thank you, Cecily. Rosemary?
Yeah,
I'll give you 3 minutes.
Yeah, the question around debt to health. I think two things to say around that. One is that we have found it's very difficult to be successful around debt to health without an institution that is helping the country to negotiate. Where we have been successful is where the Global Fund has stepped in to support those negotiations. So most of the successful debt swaps, which we call debt to health, that we know have been successful, and there are multiple. There's on the Global Fund website, there's a link that takes you to the history of the debt to health, where, for example, I take one example. Last year there was a debt swap with Indonesia. I don't remember the donor country, and it's one of the latest ones. But I know the one for Cameroon a couple of years back, where Spain cancelled a particular amount of debt that Cameroon owed. And so Spain requested the Global Fund to work with them around this, and the Global Fund negotiated around that. And so how that happened is that the debt that Cameroon owed Spain was cancelled, but it counted as Spain's contribution to the Global Fund. And so how that happened is that instead of Spain actually making a financial contribution to the Global Fund, this debt was cancelled, and Cameroon was going to count that and to invest. Instead of sending the money back to Spain, it was going to invest that money in HIV, TB, and malaria programs at the country level, which then were counted as Spain's contribution to the Global Fund. Anyway, it can get a lot into the details and technicalities, but I think there are some conditions that actually facilitate that. And that's one, to have an organization that is facilitating those negotiations. The second thing is that in other debt swaps, one of the other challenges is usually that when the loan is cancelled, especially in the absence of a negotiating organization like the Global Fund, you have no guarantees that that debt cancellation is going to result in more investments in health, because that debt cancellation, that amount of money could go to anything. And so it becomes difficult then to get that earmarked for human capital investments. And so I think just key highlights. To Sochil's question around human capital being one of the most important, I think, investments that contribute to job creation again, I think there are many things to invest. I think in the Africa region, and this is a question I was following up in the IDA forum, is to think how the Africa Human Capital Plan can be revamped, because in the previous one, they even had ring-fenced to say that for this, I think it was, I don't remember which IDA that was, but there was a commitment that for Africa Human Capital, IDA was going to make a contribution of a particular amount of money towards the Africa Human Capital Plan, which I think is important to cover all the aspects, whether it's wasting, whether it's all the different elements, universal health coverage, and so on and so forth. So I think the plan, like we don't have the framework, I think that can be a starting point. Yeah.
Thank you very much, Rosemary. Waiswa,
No,
any last minute reflection,
no,
conclusion?
I think on the jobs agenda, no, I don't have anything to add to that. Thanks.
Great. Thank you very much. I know Honorable hasn't joined us back, but if so, maybe I would have loved to give him for his conclusion on the topic. Thank you very much, our able panelists. Thank you, our participants, for being patient with us and also having this wonderful discussion. Okay, please. A lot has been said, and maybe to concluding this would not be really fair, but just to attempt to summarize some of the things that have been raised. There has been a point on intersectionalities in the different approaches that we have done, and also to make sure that we complement each activity that we're doing and not really compete with the different activities that we're pushing for. And within that, we can also have our reprioritization, or kind of coming back to the board and see how we can prioritize. It's been mentioned, country context really matters, so we need also to make sure regional plans, global plans also are addressing the gaps, the identified needs and priorities of country plans, which is very much important. Honorable mentioned about the lack of private sector engagement and participation, especially within the job creation agenda. I believe private sector can play a lot, and within that also trying to have a more targeted approach in terms of the structural investments that we make. For example, we're talking about health nutrition. If there are investments on vaccine manufacturing, therapeutics, in turn also this can create jobs and also address that. Low absorption capacity, governance just not directed towards government or other institutions, but also towards us, the civil society and communities, understanding the frameworks, the commitments, and making sure also that accountability reflects back to us. So also in a way we can refer to it as self-accountability. So this is in summary, but to summarize and to conclude all, human capital investment, human capital prioritization is also another thing we need to be mindful about. This is what we have for you, and we're very much happy that you could join us. Thank you very much.